Hey, good afternoon, everybody. Thank you for coming to assemble with us for this afternoon workshop. We have two amazing PAs that I'd like to introduce to you who will be your instructors for this afternoon. Doris Hansen, who is a MS-PAC, is a board-certified physician assistant at the Toronto Cosmetic Surgical Institute, also known as SIX Surgery, located in downtown Toronto. She also has a part-time position at Biopharma Clinic in North York as a subclinical investigator for phase 1 clinical trials and bioequivalent studies. Doris graduated from Wagner College PA School, where she completed her undergrad and master's in a 5-year program. She has worked in various specialties in locations including pediatric neurology in Brooklyn, New York, a traveling primary care PA in rural California, and reconstructive and hand surgery in PA in Cooperstown, New York. Currently, she's been working in Toronto for the past 2 years and has been actively advocating for the PA profession, hoping that it can live up and be valued at its full potential. It will. Doris has done a previous workshop with Kappa and is delighted to return to our conference in person. And I would also like to introduce you our PA, Amanda Perota, who has a CCPA, Bachelor of Science PA, and other Bachelor of Science, which is Honors Kinesiology. Amanda is a Canadian trained and certified PA, a 2018 graduate of McMaster University's PA education program, and has been the Vice President of McMaster's Physician Assistant Association. She continues to offer her mentorship to first-year PA students and prospective students. So prior to this, Amanda earned a Bachelor of Science with an honors specialization in kinesiology at Western University. With previous research experience and publications, Amanda is a lifelong learner with an ongoing interest in innovation and evidence-based medicine, specifically with surgical oncology and reconstruction. Amanda is currently working at the University Health Network in Toronto in the Division of Plastic and Reconstructive Surgery since her graduation in 2018. She is the inaugural physician assistant within UHN's Breast Oncology Reconstruction Program. She functions as a physician extender in perioperative settings, assisting in microvascular and breast reconstruction surgeries, and providing both inpatient and outpatient care. Amanda is involved in a number of research projects within the department with a focus on quality improvement and patient safety. She provides a level of consistency among surgical patients and in high volume academic center and assists in the orientation and teaching of the medical learners at different levels from around the world. Amanda's career goals include further enhancing her surgical and procedural skills, as well as to conduct further research on the efficiency of a PA within plastic reconstructive surgery in Canada. So welcome, Amanda and Doris. Thank you.
I can try it, yeah. Hi, guys. Welcome. Thank you again for that lovely introduction, Leslie. So good to be back here. So nice to be in Quebec again. For people sitting in the back, try to sit at a table that has all the equipment on it, just so we can get an idea of how many people need the workshop materials. Yeah, feel free to move in. I have a bunch of slides that I'm going to run through very quickly. So if you have any questions, you can hold it to the end just so we can get more hands-on. And let's get started. Yeah, wherever you guys see that there's like a suture stuff and materials, you can have a seat. And then everyone else, this table, we will get you something. We were limited on supplies this year due to like last minute arrangements. So we're going to be sharing quite a bit, and we're going to be creative in how we use the stuff provided to us. So yeah, maybe you guys can like join in other tables, like break up and join in. Okay. And just starting off, last time I was in Quebec was over 10 years ago, and I actually went to the Ice Hotel There's only 2 in the world, and they rebuild it every year, and it's just like magnificent creativity and what they can do with the snow and the ice. So it's good to be back. Today I want to enhance your clinical skills, try to talk about benign and malignant skin lesions, addressing those skin lesions, reading pathology reports, wound care. And then the final part that I added on this year was finger injuries, splints, and non-surgical finger injuries. So the clicker is working. That's pretty good. Yeah. Okay. Okay, so with the skin, just a quick review of anatomy. How many people here, just a show of hands, like are in primary care and already use biopsies regularly? Okay, great. So this will be kind of a review for everyone. Okay, so the skin is the largest organ in the human body, and it acts as a mechanical immunological barrier and a thermoregulator. 2 layers, epidermis, dermis. And then this is just a basic overview of the layers of the skin. This is just strictly the epidermis. So we have the basement membrane, the stratum bacilli, melanocyte, stratum spinosum, stratum granulosum, stratum lucidum, and stratum corneum. And then the stratum lucidum is the only one that's not throughout all of our skin. It's just the layer in our hands and palms and our feet. So these are the main layers, and then the glabrous skin, which is the palms, have the extra layer, the stratum lucidum. That's there to help kind of like stick down the skin so it's not moving around. And then you have all these cells within the epidermis layer, and then we have the dermis layer, and then you have all these cells within the dermis layer: fibroblasts, mast cells, histocytes, monocytes. And these are where your collagen, elastin is, and your oil glands, hair follicles, and you have 2 different types of sebaceous glands, your eccrine glands and your apocrine glands. And the main difference between the eccrine and the apocrine is apocrine is like your hormonal sweat glands. So these are areas like your axillary areas and your groin areas. And this is common with people who have what's it called? Hidradenitis suppurativa. Yeah. So you'll find those in those areas because they're the hormonal glands. And then this is just your classic overview Fitzpatrick grading scale. So whenever time we're writing like a note and you want to grade your patient's score, you guys are probably all familiar with this documentation again, like patch, macule, papule, plaque, pustule, and vesicle. And vesicle is fluid filled. Just gonna run through these. These are like things that I was like, oh, I haven't used this word in a long time. So I just threw it in there. Okay. Benign lesions, you have your nevus or your melanocytic nevus or nevi. And nevi are usually acquired after birth. And they're just a concentration of nevus cells. So they're usually in the location of the epidermal-dermal junction, ED junction. And then you have your intradermal nevi or compound nevi are both in the dermis and at the junction. These are benign. We can skip through this. Okay, congenital melanocytic nevi, and these are usually present at birth. I have a few. Wait, how do I go back? Okay, I thought I had a picture. So, you know, if you do pediatrics, you know, sometimes the parents will be very nervous about these things, and if they're born with it, then it's usually okay. But we'll talk about other pediatric skin conditions that may require biopsies. Blue nevus, people come in panic because I think it's a melanoma, and it's just a bluish nevus. It's usually smooth surface, and they tend to be blue or gray. And sometimes these are hard to pick out depending on the lighting or where you're working. So that's why you do use a biopsy pretty much for everything. Halo nevus, these are when the borders are not very sharp. So again, people come in because they're like, oh, the borders are irregular and they're not sharp. And, you know, they see online that it doesn't fit the ABCD criteria. So they come in, but usually these are also benign. Spitz nevus. Yeah, this was it. The Spitz nevus, pigmented, again, just to familiarize and kind of go over all these things. Hamartomas. Okay, actinic lentigo is the medical diagnosis for sun-exposed areas. And usually you can see it like on people's arms, most likely affected, and their face and neck, chest area, especially if they have an occupation that requires for them to be outdoors for majority of their work life. And we'll talk more about that too going forward. Freckles, ephelides is a medical term. We all know what that is. Seborrheic keratosis. These are probably like one of the most common things that people come in for. At least, I don't know, at least where I used to practice. And again, these are benign. They're called like age spots or liver spots. Nothing really to worry about. We'll talk more about like what to look for when, trying to have a differential diagnosis. Yeah, and the classical textbook thing is like stuck on or waxy appearance, like every time you get tested or questions. Keratoacanthomas. I have a lot more about this, like keratoacanthoma. They're usually the history is a rapidly growing lesion, and patients come in right away for this because they have like a central keratotic core, so it's not a very pretty looking lesion, and they get really panicked. And with time, it can actually regress, but most people don't like the appearance of it and get really freaked out that they want to excise right away. And this is like something that you can do in the office, depending on the location, of course. If it's somewhere on the face and, you will need a referral for that. But, if it's somewhere else on the body, you can pretty much take care of it on your own in an office setting. So this is it. So this was a patient that came in, and I think I did like a shave biopsy on her. It had the history of a keratoacanthoma. And then this is just a typical pathology report just to familiarize how to read one and what this means and where to go from there. So it was a skin lesion on the right lower arm, and this was excised, and it says benign keratoacanthoma lesion completely excised. Can you guys see that? Can you see the print in the back there? Or no? Okay. And then I think I did a left cheek biopsy on her, and then it just says benign keratosis, suggestive of lichen simplex chronicus, which means like she just scratched it a lot. So benign. Oh, okay. Chondrodermatitis nodularis helicus, big name, benign, and patients come in. The distinct history for this is that it's painful. This can commonly be confused with like a basal cell skin cancer, but the distinction is the pain. Usually patients can't sleep on that side. Older patients get affected by this, I find. So yeah, it resembles a basal cell, but I think pain is like the most common thing. It's you can either use you can either freeze it or you can biopsy it if you're really concerned and you're really not quite sure. So this was a pathology report for that one, for chondrodermatitis nodularis helicus. It's a long name. I'm just trying to see if there's anything here that we really need to know. So excision. Section entire submitted as follows ends. Okay. Verrucous nevus, these are like warty-like lesions. Acrocordon, yeah, these are skin tags. So fancy term for skin tags. I don't know if like the billing system, I remember like when I was in the States, like we used to bill for our own like excisions and things like that. And like if you use acrocordon instead of skin tags, it was like you would get more like more money, basically reimbursement for it. So same thing with like if you put like history of like CVA versus history of stroke, you just get more. I don't know, just the billing system is totally different there. So actinic keratosis, these are pre-malignant skin lesions. We'll go, you can use cryotherapy, and if they have like some people come in with like just their entire arm is covered with it and face, and so you can use a topical cream, 5-fluorouracil. Or like they can do chemical peels. There's now lasers, but usually 5-fluorouracil is the best method, cheapest and accessible. Leukoplakia, we're not going to go. Cutaneous horn. So these are also pre-malignant. They're not very pretty. So this is a cutaneous horn. And usually I just like shave this off and I try to get like at least like most of the epidermis on this part. So these are kind of classified as squamous cell in situ, also known as Bowen's disease. They're scaly surface, irregular borders, ulceration, bleeding. We don't. Hair follicle tumors, just basically biopsy everything if you're not sure. Eccrine, apocrine tumors, there's so many of them. Okay, pyogenic granulomas is a mesenchymal tumor. And there's nothing pyogenic about it. It's just basically a vascular nodule that patients will come in with like, oh, it just constantly is bleeding. And this could affect any age range. I've had like children come in with this. Very strange, but you can't just cauterize the tip of it, which I did in this patient. She came back like 2 days later, was bleeding again. You have to remove the entire thing and have the skin grow over it. Otherwise he will keep coming back. Dermatofibroma, also a common thing. Basically it's just scar tissue and it's like this thickened nodule, usually discolored. Okay. So this is usually the setup that I have. It's sterile, and then we'll try to simulate that today. So you just have from the left to the right, the blade handle, forceps. That's a punch biopsy, which we do not have today, but I think that's a 3 millimeter punch biopsy. Scissors, and then a needle driver, and then I usually use the 5 absorbing fast. And then cryotherapy is liquid nitrogen. And usually I use this for actinic keratosis, seborrheic keratosis. Anything that's like flesh colored, you can use it for if it has like pigment. Like we spoke about the melanocytic nevus, it doesn't really work too well on those. So usually you have them come back in like 4 to 6 weeks just for the process of it to heal and flake off. So, and then you can do more sessions. Okay, so skin cancers overall, these are the most common form of cancer diagnosed in the US. And this includes like basal cell, squamous cell, all of them. They're cutaneous malignancy, and 1 in 5 people will be diagnosed with skin cancer, so it's important. This is just a question. 70-year-old male, worked as a gardener most of his life. I think I took this from like a board question. 8 millimeter pearly white papule with a central crater, telangiectasias and rolled border. I mean, that's like your typical thing, typical basal cell. So the man says that it's non-pruritic, frequently bleeds after he shaves. And then what's your recommendation on this patient? So usually, what's a shave biopsy and Mohs surgery, but I don't know. We rarely refer to Mohs surgery unless it's like on the face or something like that, or if it's like massive or but this is again a question from the board, so they never do anything they never do anything practical. So okay, so basal cell nodular, classic shape is nodular papule. Then you have your superficial, and then your morpheiform, which is the more aggressive type. This is a 53-year-old female, skin lesion. Oh, hold on. I actually think I'm not sure. I think this was a basal cell too. I don't remember, but 53-year-old female presents with skin lesion on her neck. And then they did exam reveals 3 to 4 millimeter keratinized nodule, central ulceration, symmetric border. She admits to picking it a couple of times. They always try to throw you off by like how they say that they pick on it, and that's why it's bleeding. But which of the following is a diagnosis? So this is squamous cell. This is a nodular squamous cell. And then squamous cell is the second most common type of skin cancer. If diagnosed early, it's curable, but it can actually develop and metastasize if you don't treat it. Okay, this is just like invasive squamous cell is a categorizing classifications. Okay, so what to do now? So this is a workshop part. Basically biopsy, if you're in a clinic or you're not really even sure what the lesion is. Biopsy is like the best method, even if you are kind of sure what it is, but you want to have a guarantee, or you're going to refer to dermatology, and that's going to take like anywhere from 6 months to a year for them to get in. And you've already tried, even for rashes and stuff, like you already tried topical, steroids or topical creams and stuff. So I think biopsy is really an essential tool that I think pretty much all healthcare providers should know. And I think we should really be taught with those tools just because of the capabilities that come with that, including like how to inject local and feeling comfortable with making the patient feel comfortable with like the local and allowing them to not feel pain. And then the other options, as I mentioned, is the cryotherapy, excision with negative margins, and then the topical 5 fluorouracil. Okay, and then you always have the patients that don't really have they're poor historians. I mean, I would definitely biopsy. I don't even need to take a history, like, and probably I would refer this to plastics just because it's going to need a wider excision. Okay, so we'll just run through the local anesthetics. Steroid injection for biopsy or steroid injection anesthetic. Okay, yeah, so just a patient comfortability, like being comfortable. And it's intradermal or subcutaneous. So usually we use like lidocaine and epinephrine. And we can always use epinephrine. I use epinephrine every part of the body. I don't have any restrictions like for fingers or anything like that. Because the duration is very short. It's just talking about the molecular structure of lidocaine and the breakdown of it. And most people are not allergic to it, despite what they may tell you. Epinephrine, as we know, is a vasoconstrictor, so you definitely want to use that wherever you are in the body. Oh yeah, and epinephrine takes about 5 minutes for it to start working, but you can always start ahead of time. Okay. Depending on the area, if you're doing like a 2 to 3 millimeter biopsy, usually like 3 mils of local is perfectly fine. That's yeah, even like 1 mil, whatever you feel comfortable with, but you want to just keep in mind that the patient is comfortable and stuff like that. So we have 22 gauge needles, so we're just gonna use that today. That's that. Oh, and I just have photos of like, things that kind of like look almost benign, but like you're not really sure. So you just want to play it safe and biopsy everything pretty much. This one was very weird because it looked like a seborrheic keratosis, but then like underneath was this other growing thing that was like lifting it up. And then we talk about melanomas, and obviously this is the most deadliest form of skin cancer. And just the demographics of it and who it affects. So it's the 5th most common malignancy in men and 7th in women. And obviously preventative measures, taking a good history and a family history can be essential here. And these are the risk factors for melanoma, which is different than the other skin cancers. So I'm not going to read through all of them, but the familial one, these are interesting because they will, on the pathology report, will report whether or not it's like in the CDK and 2A. They'll test for all these medias, sun exposure, UV, and obviously sun protection is key. And if they've had a melanoma in the past, they're more likely to get one later on in life too. So if that's in the history, then definitely biopsy it, whether it looks benign or not. ABCD's characteristics. Okay, just for superficial spreading melanoma, trunk in men and legs in women, age 30 to 50. So these are just like from nodular. You can have one. Some of them will look like a hemangioma and stuff like a darker hemangioma. So these were actually melanomas, and you have different types. So this is the lentigo maligna melanoma. This one is acral lentiginous melanoma. And this is the most common one found in African Americans, affecting like the palms of the soles of the feet and the palms of the hands, where melanocytes are not really produced. So this is a melanoma. So they don't really look like your typical presentation of a dark growing, irregular borders. They can look like a nevi. This is a desmoplastic one. I think I had a patient that had one on her arm, and it literally looked benign to me, but she was like very concerned about it. And so like, I was like, okay, well, I just shaved it. I mean, you should really do punch biopsies anytime you suspect a melanoma, just to know the depth of it. But for this particular patient, I shaved it, and it was like a desmoplastic melanoma. But I think the other thing is like, just like listen to the patients, because I feel like they know their bodies a lot better than you do. And it's also safer to practice that way. Biopsy. Okay. So yeah, it's both establishing and diagnosis, and helps provide staging and prognosis for the skin cancer. And it can give you like 5 to 10 year survival rates, depending on where it falls in the classification, depending on if it's like a squamous cell or a melanoma. So, and you can do multiple biopsies in the same site. So like if you have different lesions all around, and, just the labeling should be different, but you can do the same during the same day, you can inject and biopsy. And as I mentioned before, shave biopsy should not be performed with melanoma, especially when you're suspecting like a deep positive margin. So this is not this is melanoma that metastasized. So this wasn't a primary lesion. Okay. So this is just a typical thing, written and signed consent. Always take pictures if you can, if you have an option to do that in your charting. So typically, clean the area, betadine cyclophrep, and then you can use a dermablade or just a regular 15 blade. Today we have 11 blades, so we're going to improvise again. And then pathology container for specimen, and the silver nitrate sticks. You can use aluminum chloride if you have it, Moncels or Surgiform. Depends on what you have. And then just a dressing. I usually use like bacitracin and Band-Aid or something. Oh, I have a video. I don't know where that is, but okay, punch biopsy. So yeah, for punch biopsies, which we don't have, but you can use 2 to 3, even 6 millimeters. Really 2 millimeters is sufficient, and it's very quick and easy to do. You could just do like 1 ml of local, take a small piece of it. You don't even have to put a suture in it. You can just use silver nitrate and cauterize it depending on where it is. Especially if it's like somewhere on the face, like less is more. And you want to just get a full thickness. So you want to like, don't be afraid to go all the way down with it. I don't know if this is a video or not. Can I press? Oh, there's nobody there. Let's see. We have Amanda doing our technical support today. Okay, cool. So this is just me cleaning the area. I don't know if all the, this is me like really taking extra precaution. Now it's just like, just rapidly one and done. Okay, can we like fast forward? I'm just cleaning. I'm prepping her for surgery here. Is there another video or no? Is there another one or no? Okay, this is just me doing the local. And I usually just go around it. If you need to mark it, if it's very small, you want to mark it first, you can mark it first. Okay, so just injecting. And then you also go deeper too. Oh, that's it. Oh, is this a different one? Or is that the same one? Okay. No, I think this is when, can you play this one or no? Oh, that's me putting bacitracin. So I already did it. Okay. And done. It's pretty quick. You don't even really need all those sterile towels. This is just like if the college came around and wanted to investigate, maybe. All right. So how to interpret pathology reports. We already kind of went through all this. And this one was for a melanoma. So it was a left cheek skin biopsy. And you guys usually read the pathology reports when they come in? Yeah, so this was in situ melanoma, lentigo malignant type. So it's always good to kind of give the patients their results and explain it to them in detail. So this is pretty good. And so it says down on the comments, it says invasive melanoma is not identified. However, in situ melanoma extends to the peripheral margins, and therefore this biopsy may not be representative of the entire lesion. So this is the type of thing that if you took pictures ahead of time, this is good. And then you want to go back and excise the entirety of it. So you can do like an ellipse. Depends on how big it is, but okay. And this is just like the criteria now for melanoma. It's like sentinel node biopsy, PET scan. And then they have like the different stages based on the stages. They have their 5 to 10 year survival rates. We can just skip this part. Yeah, and then you have patients that come in with like all this stuff, and you're like, oh, which one should I choose? So you can like biopsy a few of these, but you can also do like cryotherapy, just have them come back in. You can take pictures and then have them come back in, like kind of do a closer follow-up. Oh, of course, take a good history on these patients. It's another pathology report at the tip of the nose. Let's see, basal cell infiltrative features present at the specimen margin. So again, this hasn't been completely removed. You would have to go back and have it completely excised. And these are some things that you can either send to Mohs surgery, or they can, plastic surgery can do some sort of flap with it. Or a skin graft, but usually the nose is like a flap. Skin cancer again. These elderly patients with like this very thin skin, usually I just do like a 2 millimeter punch biopsy, and then I cauterize it, and then I wrap it a lot. This squamous cell. This is like one of the pediatrics one where it's called the nevus sebaceous of Jaddison. Just to keep you guys like aware of different types of diagnoses, because there could be so vast, but you don't want to just brush it off and say, oh, if it's a child and stuff like that. This is just a cyst. I wouldn't do a steroid injection to the cyst. Just excise it. You could do steroid injections to smaller cysts on the face if you don't want to, cause scar or harm, but it has to be very small. Like I would say like 4 to 5 millimeters max. And then steroid injections are commonly used. I wouldn't, maybe not for inflamed cysts, but for hypertrophic scars, keloids, cysts on face, including cystic acne, and then certain keloids. For what? Steroid? For cyst. Yeah, there's yeah. So, I mean, yeah, but it's like dermatologists, I feel like we'll just inject it and see what happens. And if it comes back, then they'll get it excised. But yeah, you can, but you can always offer that to them. If it's small enough, you can always offer that to them, because some people don't want like, even like a linear incision in their face. But yeah, but you just like talk to the patient. It can get infected. It can grow bigger. It can go away. Like there's always these risk factors that come into play, and kind of like talk about your plan with them. But yeah, they don't, not necessarily always come back. Some of them like do well. I don't know. Yeah. 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 If you leave the sac part, it can definitely come back. Yeah. Sign consent, triamcinolone, which we don't have today, but we can also use this for trigger finger injections into the A1 pulley, which we can talk about too later on. These are keloids. That's the pyogenic granuloma again. Hutchinson freckle. This is in melanoma in situ. This one I just sent to oculoplastics, sebaceous carcinoma. These are just like things to review. Like this one, I just debrided his wound. He had some, he had multiple numerous surgeries and a lot of plates in his foot. And he just had chronic wound healing issues. So these are just like some certain things like just to keep noted for wound healing. It's good to keep it moist, but not too moist. Limit the edema so you can wrap it. And then debridement, just to have some healthy skin tissue and allow it to bleed. And there's a lot of healing agents out there. Marjolins ulcer is like when you have a wound that never really heals. So you want to biopsy that too, because it could turn into a cancer, skin cancer. These are some adjunct wound care things that are out now: fat grafting stem cells and enzymes. Those are like the newest ones. And then hyperbaric oxygen if you can, but it's expensive. Oh, and these are the finger injuries. Okay, so we can like get started on the biopsy part and then like kind of go from there. I don't know if we'll get to the finger stuff, but it's just an overview. But all right, let's do it. So you can grab gloves in the middle, and then each table should have pig skin, and we're gonna have to share like the silicone things and the pig skin. For the silicone trays, we cannot do like any punch biopsies or any excisional things from that. You can use that pig skin to practice with. And then I have some sutures there too. We have nylon sutures, silk sutures. These are non-dissolvable. Yeah. Okay. Also guys, when you're drawing up, I want you to practice like drawing up the local, but we have only like a saline bag. So we'd have to come and get the saline bag, like the solution from the saline bag to draw it up. Okay, so just start as you would, like if you were actually having a patient, you would inject local first. So I just have the saline here.
Guys, just a friendly reminder, when we're cutting, just don't cut the silicone. Like, don't cut anything out of the silicone. Try and cut the meat. Don't excise. Yeah, don't excise. Just, you can slice, just not excise.
If you guys need help with how to put the blade on the handle, let me know. I can come around. And for some biopsies, you don't even really need a handle. You can just use the blade. Usually oh, just so I can have your attention. When you're doing like an ellipse excision, usually when you're marking it, you want to make sure that the length is actually double the width, just so it can come nice, like just for the, just so that it can come nicely together, like the edges can come nicely. So usually the length is double the width. So usually you measure the width first. You have your marking pen around the lesion and then you measure the width of it over like where you want the margins to be. And then you double that in the length size. And it ends up being big, but like when you put it together, it's just like a fine line. If your table is missing any materials or anything, we have lots on the side here, so I'll bring you a forcep and just let me know. Hey guys, if you need to take a break, you guys can take breaks. I was just gonna jump in to review like the finger stuff while you're working. You can continue working and stuff. We're probably not gonna utilize all the time. It's 3 o'clock now, but how are you guys feeling? Do you want to like practice some more, or you want to go into fingers? You want to take a little break? Fingers? I got one table of fingers. Table in the back. You you are turning around. How are you guys feeling over there? Okay. All right. Okay, so I'll just jump into fingers. It's basically an overview of anatomy, and it's just talking about like certain finger injuries that are common and what you can do in a basic primary care setting versus like what you need to refer out to see, like be seen by a hand surgeon, plastic surgeon. So just a review on hand anatomy. Anytime you're like talking to a surgeon and you want to refer a patient, you want to use the hand anatomy terms because it varies with the hand. So you have the volar side, which is the palm of the hand. And then you have the back of the hand, which is the dorsal side. So instead of like anterior, posterior, it's volar and dorsal. Pretty basic. And then volar or dorsal. So which one is this? Good. This. Awesome. All right. And then hand anatomy again, first and second digits. So your thumb is your first digit, second, third, fourth, fifth. Again, it just like looks more professional when you're not like, oh, the pinky finger was injured or, you know, and then radial side, ulnar side. So instead of lateral or medial, the hand kind of gets distorted with depending on the position. So we base it off of like your radial or your ulnar side. So where your radial nerve runs and then your ulnar nerve. And then proximal and distal. So that's pretty much the same as it is throughout the rest of the body. And then this just goes over the radial and ulnar side. And then you have the hand anatomy by itself is like very complex. Just doing a brief overview. We're not going anywhere near the wrist bones, but just they're called carpals. Then you have your phalanges and then your carpals, which are the wrist bones to your fingers. To your metacarpals are called the CMP area. And then you have your metacarpals to your phalanges, which are called the MCP area. So metacarpal phalangeal joint. And then you have your carpal metacarpals joint. And then this is just a picture of that. And then the fingers, you have your IP joints, which are your interphalangeal joints. And the thumb only has one. So when you say the first digit IP joint, there's only one. So you know what they're referring to. But then for the rest of your fingers, you have your distal IPs and then your proximal IPs. So we call them PIPs or DIPs. Your collateral ligaments. The fingers are made up a majority of ligaments. So you have your collateral ligaments, your volar plate ligaments, and then your extensor hood slip. And A1 pulley, that's where we inject the for trigger finger. Let's go over this volar plate. This is your volar plate ligament, and we'll talk about like injuries to the volar plate ligament and what the deformity looks like. And then your extensor hood ligament if they get an injury there, like a jammed finger. Okay, and then getting a history is important. You want to know how long the symptoms have been going on, form the mechanism of the injury. Was it a repetitive trauma or is it just something that happened one time? And you want to know another important thing here is the force involved. So if it was like a machine injury, you want to know like how much pressure is on that like finger or hand. And then is it continuous or intermittent with the pain? Hand dominance, of course, that's important. And other things to note is like if they're nicotine users, it can cause vasoconstriction, thank you. But it also causes like a vascular issue. So sometimes the skin may appear to be like dusky with certain injuries. So you want to just keep aware of that, whether it's like a nicotine user or not. Diabetes and chronic disease, like Berger's disease, surgical history, prior trauma, if they have hardware, Dupuytren's contracture, congenital conditions. And then these are just like infections, paronychia and felons. And then the basic idea here is like what to splint and what not to splint. People think they need to splint a trigger finger and usually not indicated. They may feel more comfortable, but we like to have the mobility of the finger. And then for splints for infections, we don't usually splint them. Again, mobility is more important than anything because the infection will eventually heal, but you want them to have that capability of being able to move their fingers again right afterwards. But sometimes we do put like a light dressing like a bulky dressing on a finger infection, just because of if they do accidentally hit it, then it's like very, very painful. Carpal tunnel needs a splint. Guillen's tunnel needs a splint. This is more for symptomatic relief, and then right after surgery too. But then after that, they're fine. Tendon injuries are 100% need a splint at all times. And just to talk about mallet finger, because we used to get a lot of referrals for mallet finger, and usually the patient, so this is a finger jam, that's usually the cause of the injury. And then we have like, you just use a stack splint, like one of these, you have to find the right measurements, and you just wrap it with Coban, and they have to keep these on for like 6 to 8 weeks, depending on when the injury occurred. A lot of these people will come in later on after their injury, like a couple of weeks after, and they're like, oh, my finger is not straining anymore. And you're like, when was the injury and how did it happen? So it's important to like talk about this as far as timeline. So you shouldn't be able to, it should be in extension completely. And then some people will, sometimes they'll come in with these splints from the ED or urgent care, and it's not really doing anything because it's not really protecting the volar aspect of the finger. So they can still have the ability to flex it. So you want something more of like a stack splint where the finger is an extension constantly for mallet finger injuries. Boutonniere, these usually arise from arthritis or RA, birth defect. Just to go over swan neck deformity. Yeah, and another reason why you want to ask about how the injury occurred is because if it's like a blade, if they cut, you want to see if they cut down to the tendon. Jersey finger is a rupture of the flexor tendon. This is when they can't flex it, and this is actually a surgical treatment, nothing to do with a splint. So this is just a typical picture of what I see commonly. 48-year-old female, urgent care. She cannot straighten her finger for the past 2 weeks, and then she recalls maybe injuring it while working out at the gym, and she just iced it, and after a few days the pain went away, but now she doesn't have any pain, and she's right-handed and works as a cook. So no apparent, this is just like what you write in the examination. No apparent open wounds, no swelling. So you want to address the anatomy. So third digit DIP joint appears to be flexed and sensation intact. So I don't know if you guys know how to do like a full hand exam, but when it comes to sensation, you just like the nerves run along the sides of the hand. So you want to just like touch the outer tip and then touch the inner, like the ulnar and oh my God, I just forgot the radial side. So third digit DIP joint is which joint? Can you guys like stick your finger on? All right, thanks. I want to see if you're still awake. Okay, so the plan is like to immediately put this person in a splint, and not to take it off, even like if they're washing their hands, like usually I'm just like put a bag around it, but they really need to wear this like religiously. And they could just take it off to shower if they need be, but they have to wear this for like 6 to 8 weeks, especially if it's such a late injury. And you have to let the patient know that there's not even a guarantee that the finger will straighten on its own, that surgical intervention may be required if it's not straightened after like the 8th week. And that's it. No. Yeah, always try it first. Yeah, absolutely. Yeah. And that's just me. I also, when I was in Quebec, I came for winter carnival d'hiver. And yeah, it's like so long ago, and then that's it. So we can continue on doing that. I can come around with the finger splints, and I can show you how to like buddy tape and use these things for stack splints. Okay. Do you guys have any questions? Even like about the surgical, like the biopsy part, even though we didn't have any biopsies. All right, cool. I'll just come around and we can continue working from there.